Chapter 21, Part 2 of War Surgery from Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Dr. Beth Thomas. War Surgery from Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 21, Part 2. Operative Treatment of Special Conditions. A. Wounds of the abdominal wall with non-perforated prolapsed gut. After shaving and thoroughly cleansing the skin of the abdominal wall, the wound to the extent of 1/4 inch around the prolapsed gut is carefully excised, care being taken not to touch the peritoneum. It is rare to find the peritoneal cavity infected when such a condition exists, for the prolapsed gut and omentum act like a cork, the serous coat of the prolapsed gut becoming sealed to the rent in the peritoneum by exudate. While the excised wound is carefully protected with a sterilized towel, the prolapsed gut is well washed with warm normal saline and returned to the abdominal cavity. Although the loop of the gut has been soiled, little or no harm has resulted in returning it to the abdominal cavity. The abdominal wall is finally repaired and sutured. B. Wounds of the abdominal wall with perforation of the prolapsed gut. After thoroughly cleansing the skin of the abdominal wall, it may be possible to stitch up the perforation in the gut. Unfortunately, in most cases of this particular class of wound, the gut is so soiled and damaged that there is no other alternative but to resect the piece of prolapsed viscus and perform an end-to-end anastomosis. This part of the operation should be carried out after excision of the wound in the abdominal wall. Resection of damaged gut, the result of gunshot injury, followed by an end-to-end anastomosis, is a procedure attended with a high mortality. But if the perforated gut be prolapsed and the general peritoneal cavity not infected, which in this connection is usually the case, then the outlook is better. C. When the missile has penetrated the abdominal cavity and has not emerged, there are 3 main points in treatment to consider. 1. Excision of the wound in the abdominal parietes. 2. Repair of any damage to the abdominal contents. 3. Removal of the missile. It is sometimes possible to include the wound of entry in the laparotomy incision, but if this is not feasible, it is better to excise the wound first, suture it, and paint over the suture with masticol varnish. This done, proceed with clean instruments to open the abdomen. Repair of damage to the gut. Perforations of the gut may be either single or multiple. Single perforations have been found most frequently in the large intestine, the commonest sites being the cecum, the hepatic flexure, the splenic flexure, and the descending colon. We have only in rare instances seen a single puncture of the small intestine. Perforations of the large intestine show a remarkable tendency to become isolated, and there is little doubt that a number would recover if left alone, a fecal fistula resulting. When the abdomen has been opened, the perforation should be closed as quickly as possible with a double row of sutures, and this is often a difficult and trying task if the lesion be present in the hepatic or splenic flexures. A drainage tube down to the perforation is advisable for 48 hours, for in some instances a fecal fistula has developed after suture. After suture of the perforation, we have been in the habit of stitching over the suture line an omental graft. Sometimes an omental graft has been sufficient in itself to close the breach in the gut, and we used it in 2 cases with success where the hepatic flexure of the colon had been punctured. Multiple perforations are seen in the small gut, and the choice of operation lies between A. Suture of the separate perforations, B. Resection of the damaged gut followed by an end-to-end or lateral anastomosis, C. Enterecto-enterostomy. A is undoubtedly the operation of choice, for it is quicker and occasions less shock. The perforation should be closed with a double row of thread sutures, preferably inserted in the long axis of the bowel. This done, we have surrounded this part of the bowel with a petticoat of omentum, securing the latter in position by means of 1 or 2 thin catgut sutures. It is a rapid procedure, and an additional safeguard against fistula. B is the operation called for when both bowel and mesentery, or the mesentery alone, have been damaged to such a degree that the blood supply to the gut has been either cut off or severely interfered with. This operation in recently wounded men is a big undertaking, and is associated with a high mortality. It should therefore only be undertaken when course A is absolutely out of the question. C is called for only when the wounded man's condition will not warrant the undertaking of procedures A or B. The operation can be undertaken rapidly and involves much less handling. After the peritoneal cavity has become shut off, continuity of the proximal and distal limbs of the divided gut can be established by means of a Dupuytren's clamp. Procedure B and C are carried out in exactly the same manner as they would be for civil diseases demanding them, for example, strangulated gangrenous bowel, malignant disease, and the like. The methods are described in textbooks and call for no further comment here. The liver. The liver may be damaged either as a result of a penetrating abdominal wound or of a contused wound of the anterior abdominal wall. Penetrating wounds of the liver are not, as a rule, serious, although in one case we extracted a piece of high explosive from this viscus with a concomitant piece of clothing and found gas present. The gas infection was limited, and the patient made a rapid and uninterrupted recovery. Contused wounds of the abdominal wall have been associated with the most severe tearing of the liver and consequent intraperitoneal hemorrhage. We have operated upon 4 cases, and on opening the abdomen, hemorrhage was seen to be coming from large rents in the liver substance. The hemorrhage was readily controlled by a finger in the foramen of Winslow, while a rent in the liver was repaired by stout mattress sutures of catgut. The abdomen was closed in 3 layers after clearing out all blood clot from the peritoneal cavity, and all 4 cases made an uninterrupted recovery. The gallbladder. Injuries of the gallbladder are uncommon, and in all we have seen 3, one the result of a rifle bullet, the other 2 the result of pieces of bomb. The rarity of the involvement of the gallbladder in cases of penetrating abdominal wounds is perhaps explained by its protected position. The case caused by a rifle bullet was that of Private wounded on September 23, 1915. He was brought to the regimental aid post, where it was found necessary to detain him for 48 hours. He was hit over the gallbladder area, and later his dressings became bile-stained. He complained of much pain and tenderness. A vertical incision was made through the wound of entry, and this was followed by a gush of bile, and with it the rifle bullet. A tube was inserted, and the man left the line comfortable. We can safely assume that he recovered, because his regiment was never informed of his death. Of the other 2 cases, one was that of a German wounded in the right back by a high explosive on the Somme in August 1916. An incision was made through the right rectus above the umbilicus. Large quantities of bile escaped, the right renal pouch being full. The missile was found free in the right renal pouch. The gallbladder was severely lacerated, and there was some laceration of the undersurfaces of the right lobe of the liver. The right renal pouch was drained from behind. This man was very emaciated on admission, having lain out for 48 hours, and having been without food for 5 days. He died on the 6th day after the operation from asthenia, having gone to skin and bone. The 3rd case was that of Private wounded in July 1916. He was hit in the right upper abdominal quadrant, sustaining a perforation of the hepatic flexure of the colon and a wound of the gallbladder. Operation performed 22 hours after injury showed the presence of a general and extensive peritonitis. The rent in the colon was sutured, and cholecystectomy was performed. Death followed 24 hours later from general peritonitis. Wounds of the gallbladder, few as they have been, are of a very serious nature. If at the same time the intestine is injured, the outlook is still more serious, as bile exerts an inhibitory action on the natural resistance to infection of the peritoneum. If the gallbladder is very torn, cholecystectomy would seem to be the most suitable treatment. If, however, a small penetrating wound only be present, then either suture or cholecystostomy is the operation of choice. The pancreas. Wounds of the pancreas are notoriously fatal. We can, however, quote one case of recovery. Captain K crashed to earth with his aeroplane in May 1917. He sustained a severe scalp wound with a compound fracture of the calvarium, a compound fracture of his left tibia and fibula, and he complained of abdominal pain. 48 hours after the accident, he commenced to vomit a coffee-ground material. Associated with this was rigidity and tenderness in the epigastrium. Persistent vomiting and increased pain were present at the end of the next 24 hours, and a laparotomy was performed. The incision was medial and above the umbilicus. Contusion of the muscles of the anterior abdominal wall was present, and when the peritoneum was opened, a flaky fluid escaped. A search revealed a large tear of the head of the pancreas, from which a saneous fluid was oozing. There was no fat necrosis in the mesentery. The rent in the pancreas was sutured with fine thread, and an amental graft was stitched over the line of suture. A tube was inserted down to the wound in the viscus, and the laparotomy incision was closed in 3 layers. A quantity of alkaline fluid escaped from the tube for 5 or 6 days following the operation. The skin of the anterior abdominal wall did not suffer, as it was protected with sterilized carbolized Vaseline. The patient made a good recovery and was taking his food well and had put on weight when he left the hospital 3 months later. We saw 7 cases of gunshot injuries of the pancreas at the casualty clearing station. Laparotomy was performed and drainage established, but not one recovered. The spleen. Gunshot injuries of the spleen are usually associated with severe hemorrhage. The spleen may be simply perforated, or on the other hand it may be pulped. The latter was the condition seen in 2 cases operated upon by one of us in the line. The only satisfactory treatment of wounds of the spleen associated with hemorrhage is splenectomy. This operation was performed by one of us in 3 cases, all of which recovered. The kidney. Wounds of the kidneys are not uncommon and vary much in extent. A contused wound of the loin will frequently give rise to hematuria. A perforated wound of the loin involving the kidney, usually the lower lobe, may cause slight damage, or the kidney may be pulped. When the kidney is badly damaged, severe hemorrhage may result. The whole question of treatment depends upon the amount of damage inflicted on the kidney substance, the ureter and renal vessels. Thus, if a piece of kidney still remains attached to an intact ureter and renal artery, and this has often happened, it is best to remove the detached portion and leave the attached portion behind. If the damaged kidney be severely lacerated, but still attached to an intact ureter and renal vessels, it is far preferable to suture the lacerations and leave the kidney behind. If, however, the kidney be pulped, and severe hemorrhage has taken place from damaged renal vessels, then nephrectomy is the only course. The damaged kidney should be freely exposed after excision of the wound of entry. After the blood clot has been turned out, and any necessary repairs to the kidney completed, the wound should be stitched up, and 1 or 2 Carroll's tubes included, into which hypochlorite solution can be instilled 6 hourly. It may happen that the missile, after damaging the kidney, has gone on and entered the peritoneal cavity, causing further damage to the abdominal viscera. If this be the case, the wound in the peritoneum should be closed, through the incision planned for exploring the kidney, prior to performing laparotomy for the investigation of further damage in the peritoneal cavity. A wounded kidney gives rise to hematuria for a day or 2, and a urinary fistula may develop in the wound. This usually closes in time without further operation. It is striking how much damage a kidney can stand and yet recover its function. The ureter. The ureter is not uncommonly damaged in penetrating abdominal wounds, especially if the point of entry is in the lower loin or upper buttock. We have been concerned with 10 of these cases. Of these, 7 were complicated by injury of the intestine, and out of the total number, 7 recovered. Often a damaged ureter is complicated by a compound fracture of the bony pelvis. The injury results in a urinary fistula with a transient and slight hematuria. Immediate or late operations for wounds of the ureter have not done well, and it is far better to wait for the fistula to close. This happened in all our 7 cases that recovered, the length of time for closure varying from 3 weeks to 4 months. During the healing of the urinary fistula, the result of the damaged ureter, intervals of time exist in which no urine comes from the fistula at all. Thus, no urine may come from the fistula at all for 5, 6, or 10 days, and then suddenly the fistula may start discharging again, though not excessively for 48 hours. Eventually the fistula heals soundly, and the patient seems none the worse. In 2 of our cases the urinary fistula closed, although the ureter was completely divided by the missile and was never sutured. In 1 case the ureter was torn and contused, yet it recovered and functioned again without the help of the surgeon. Certainly this war has taught us much about the genito-urinary tract. We now know that both kidneys and ureters can stand a degree of mutilation never before thought of, and yet, if left alone, can recover and function anew. One well remembers in the pre-war period nephrectomy being performed for far less damage to a kidney than has obtained in many cases in the present war, and yet these latter cases have recovered and done well without nephrectomy. We think the lesson this has taught should make surgeons far more conservative in the matter of renal surgery after the war. The urinary bladder. Wounds of the urinary bladder are accompanied by extravasation. In most cases, extravasation has been intraperitoneal. Symptoms are typical. There is severe pain with inability to pass water, the pain being referred to the groins, penis, and sometimes the scrotum. A catheter, when passed, usually draws off a small quantity of blood-stained urine. Prior to a medial subumbilical laparotomy, a catheter is first passed into the bladder per urethrum and tied in. Laparotomy is then performed, and all extravasated urine is mopped out from the prerectal pouch and the remainder of the peritoneal cavity. The rent in the bladder is sutured with catgut, 1 row of sutures, and over the suture line an amental graft is stitched. A tube is inserted into the prerectal pouch and the abdominal wall closed. The catheter is removed at the end of 48 hours and the tube in the prerectal pouch at the end of the 3rd day. Bladder wounds have done remarkably well, and urine has been voided without trouble after the 3rd day. Urotropine has been given by mouth 3 times a day, and no complications have followed. Bladder injuries appear to heal rapidly and soundly. The rectum. Wounds of the rectum and anus are difficult to treat and to keep clean. If the intraperitoneal portion of the rectum be involved, then laparotomy must be performed, and the rent sutured in the same way that has been recommended already for any other damaged hollow viscus. If, however, the extraperitoneal portion of the rectum be damaged, and the lesion, as it often is, associated with compound fracture of the bony pelvis, then left inguinal colotomy, with frequent lavage of the distant portion of the gut with the hypochlorites, has given excellent results. If the fecal current be not diverted from the original wound, septic and even fatal complications are very prone to follow. The colotomy can always be closed at a later date. Suture of perforations of the intestine. A perforated wound of the intestine is generally associated with pouting of the intestinal mucosa. Some surgeons have advised clipping away the redundant mucosa prior to suture. This, of course, only lengthens the operation, and we have not found it necessary. We use 1 continuous suture of thread, including all coats of the bowel, and a second continuous suture, including only the seromuscular coat, the latter suture burying the former. Over the second suture line we have fixed an omental graft with 1 or 2 single sutures of thin catgut. This has in our experience proved the quickest method, and has in every way given highly satisfactory results. The peritoneum. All extravasated matter must be gently and thoroughly mopped up with dry gauze. We have not practiced peritoneal lavage and do not recommend it. 1 large rubber tube has been placed in the prerectal pouch or the kidney pouch, whichever the case demanded. A second tube has been inserted down to the damaged part of the gut. After closure of the abdominal wall, 2 to 3 ounces of ether have been left in the peritoneal cavity, and we can attribute benefit to its use, for it combats shock, it prolongs post-operative sleep, and it prevents to some degree post-operative intestinal inertia. The missile, if possible, should always be removed from the peritoneal cavity. Closure of the abdominal wall. The method of closure of the abdominal wall will depend upon whether the wound is anterior or posterior. If the wound is situated in the posterior abdominal wall, the necessary abdominal exploration is preferably conducted through a laparotomy incision in the anterior abdominal wall. This gives the surgeon the opportunity to close the rent in the posterior peritoneum. We have always done this with a running suture of catgut. This done, the wound in the back can either be left open or sutured after excision. Whichever course be adopted, 1 or more Carrel's tubes should be included in the open or closed wound. The laparotomy incision may be closed either in 3 layers or with through sutures of silkworm gut. We have tried both methods and prefer the latter. It has been our experience that many laparotomy incisions which have been closed in 3 layers have suppurated, and in 1 or 2 gas gangrene supervened. By using through and through sutures of silkworm gut, infection in the wound is far less frequent and severe, the time taken to close the laparotomy incision is shorter, and the end results are as good. Further, as there is usually much vomiting following operation, the laparotomy wound is far less liable to give way when through and through sutures have been used. Laparotomy incisions for gunshot wounds of the abdomen, whatever care be taken, are very prone to infection. This is probably explained by 1. The temporary diminished resistance to infection which most wounded men possess. 2. The wound from the beginning is often septic. 3. Extravasation of intestinal contents into the peritoneal cavity has often taken place. Laparotomy incisions are most frequently infected by Staphylococci, Streptococci, and B. coli. They are not exempt, however, from gas gangrene infection, and this grave complication, when it occurs, sets in with alarming rapidity. When tubes have been included in the peritoneal cavity and the abdominal wall closed by through and through sutures of fishing gut, we have not seen this last named complication occur. Some surgeons say that infection of the laparotomy incision is due to errors in technique, but those with experience at a casualty clearing station will agree that these cases differ from anything of the kind met with in civilian practice. At the casualty clearing station on several occasions during a rush, laparotomy for acute appendicitis has been performed in the same theatre and under the same conditions as laparotomy for gunshot wounds, yet the former cases have in most instances healed per primum. The reason is that there are fatigue, shock, and infection to reckon with in abdominal gunshot wounds, and often serious wounds elsewhere. Despite the best efforts, the men who survive these injuries and the necessary laparotomy usually leave the clearing station with a skin wound that is still open and granulating. In a few of our later cases, we have included 2 Carrel's tubes in the closed laparotomy wound and have instilled a dram of hydrochlorite into each 6 hourly. The result in 10 consecutive cases has been healing per primum in 7 and a slight gaping only of the skin in 3. After treatment. The first 3 days following operation are the most difficult and critical. The operation, however skillfully and rapidly performed, is only the first step towards a successful issue. Just as important is the after treatment, and we ascribe the greater share of the credit of success to the nursing staff who looked after and were most untiring in their care of our cases. Wounds complicating an abdominal injury require dressings which call for special care and skill. They may be of a grave description, such as a compound fracture of bone, penetrating wounds to the head or chest, or large infected flesh wounds. Men with abdominal wounds are often extremely restless and require unlimited patience. The most constant postoperative complications calling for immediate attention are 1. Persistent biliary vomiting, 2. Postoperative inertia of the gut with abdominal distension. Persistent biliary vomiting. Stomach lavage is by far the most satisfactory treatment of postoperative vomiting. We have used for this a warm, watery solution of bicarbonate of soda. Lavage should be carried out twice daily until the vomiting ceases. If stomach lavage is too distressing for the patient, which is rarely the case, then large drinks of water containing sodium bicarbonate can be given instead. Solid food in the form of dry biscuits with sips of champagne will often stop or profoundly modify the vomiting. The nature of the vomit is important. The colour is at first yellowish-green, but subsequently varies. Should the yellowish-green colour persist after 24 hours, the outlook is serious, and should it persist after 48 hours, the outlook is grave. If after 24 hours the colour of the vomit tends to get clear, that is, if there is less bile present, the outlook is good. Should a green-coloured vomit persist after 24 or 36 hours, a subcutaneous or intravenous administration of saline containing 2 teaspoonfuls of sodium bicarbonate to the pint has in many cases either arrested or profoundly modified both the frequency and nature of the vomit. Stomach lavage must be persevered with until the colour of the vomit begins to get lighter and less bile-stained. Postoperative inertia of the gut with abdominal distension. Abdominal distension is due 1. To the handling of the viscera during operation, 2. To a degree of obstruction caused by the presence of hard sibili in the large intestine, 3. To a degree of peritonitis. Paresis brought about by the handling of the gut soon passes off and requires no treatment. Obstruction caused by the presence of sibili is best treated with frequent turpentine and oil enemata followed by a large washout enema. High enemata should be aimed at, though this is not always possible, owing to the rectum itself being blocked with hard feces. On more than one occasion it has been necessary to clear the rectum digitally, a proceeding which is both painful and distressing to the patient. Perseverance with enemata has, in the majority of instances, sufficed to clear the bowel. Some surgeons, in order to prevent distension due to sibili, have performed an iliosigmoidostomy at the time of operating on the injured viscus. This procedure prolongs the operation only by a few minutes, but it undoubtedly increases shock. Further, the results gained in the few cases in which it was tried were not encouraging, and on the whole were not so good as those obtained by frequent enemata. Paresis of the gut due to peritonitis responds well to subcutaneous injections of pituitrin, or hypodermic injections of eserine salicylate, given hourly for 3 successive doses. On the 4th day after operation, castor oil may be given by mouth, and providing the vomiting has ceased, the bowels usually move without trouble. Some surgeons prefer to give calomel in 1 grain doses hourly up to 5 grains. We have tried this in cases of gunshot injury, but finding that it griped the patient and caused him pain, we discontinued it. Directly following operation, whether vomiting be present or not, we have given 10 grains of bismuth carbonate, together with 15 grains of sodium bicarbonate, in the form of a mixture 3 times a day. With this may be given tinctured camphor compound. Complications during convalescence other than vomiting and obstruction. These are 1. Severe infection of the laparotomy wound, 2. The formation of a fecal fistula. Severe infection of the laparotomy wound. This was at one time an almost unavoidable complication. Cases occurred in which gas gangrene appeared in the abdominal incision. Some surgeons who had met this complication left the skin wound open and applied a salt pack as a prophylactic measure. We cannot speak of the results of this treatment. Since the inclusion of 2 Carrel's tubes in the sutured wound in later cases, we have seen no further complications of this kind. Formation of a fecal fistula. This is, unfortunately, by no means a rare complication. When once the fistula has formed, expectant treatment should be adopted. If the fistula involved the small intestine, the skin around must be carefully protected with carbolized Vaseline in order to prevent excoriation. The wound must be constantly dressed and kept clean. If left alone, fistulae will often close by themselves, and this has happened in a number of cases which we have seen through to a finish at the base hospital. Diet. The early administration of solid food has done more good than harm, and seems to have a beneficial action in controlling the vomiting. It is good practice to give the patients dry biscuits or toast with sips of champagne the day following operation. Sweets such as acid drops do much to allay thirst and stimulate a flow of saliva. On the 3rd day, eggs, fish, minced chicken, custard and milk puddings can be given, and most patients can digest and enjoy this diet. The solid diet is gradually increased, and at the end of the 7th or 8th day, more substantial diets are usually well tolerated and enjoyed. Patients at the end of this period are fit to be removed to the base. Careful attention during the first 2 or 3 days following operation must be paid to the patient's mouth. He should be encouraged to clean his teeth twice daily, and he should be shaved and have his hair cut short. Unshaven abdominal patients with long unkempt hair are distressing-looking sights, not only to their fellow patients, but to those responsible for their care. Treatment at the base. We can record 55 cases seen to the finish at a base hospital in the Balkans. Abdominal wounds which have been operated upon at a clearing station have, on reaching the base, in the majority of instances, been open granulating wounds with a bacterial count of, on average, 10 to 15 organisms per field. The patients have been comfortable and able to take and enjoy ordinary diet. Some cases arrive in which the laparotomy incision is medial, others in which it is paramedial. Granulating laparotomy wounds on arrival at a base hospital should be rendered sterile as soon as possible by the Carrel-Dakin or other methods. These wounds can be sterilized in 8 days or less, and secondary suture performed. The stitches may be removed at the end of the 9th day, and the patients allowed to get up. The average time spent in bed for 55 cases, reckoned between the time of receiving their wounds and the time of getting up with the wounds healed, was 26 days. At the end of 6 weeks they were fit to go on a hospital ship, as they were able to walk and look after themselves. After the end of the 5th week, some of the patients complained of pain on micturition, others of constipation and painful collections of wind. These symptoms were doubtless due to early adhesions. Potassium iodide with tincture of belladonna was often all that was required to give relief. Abdominal patients should be given a teaspoonful of paraffin night and morning. This dose was quite sufficient, for the tendency in the Balkans is towards diarrhea rather than constipation. The abdominal scar. When paramedial incisions for laparotomy have been employed, the final scar was sound, and there was no tendency to hernia. This did not obtain, however, in the case of medial incisions. In nearly all the latter cases there was pronounced weakness of the scar, with herniation of the abdominal contents, ventral hernia. Thus it is, from the point of view of subsequent herniation with the formation of adhesions, far preferable to use a paramedial laparotomy incision whenever possible. Statistics. The following lists comprise a series of abdominal injuries operated upon by one of us at a casualty clearing station in France, and also a series of cases reaching a base hospital in the Balkans, some of which were operated upon at the casualty clearing station, the remainder being operated upon at the base. We would state that of the series operated upon in France, moribund cases were left alone, because with a continuous rush of wounded going on over 3 months, it seemed incorrect treatment to forfeit the lives of those who could be saved for the treatment of hopelessly moribund men. Further, we could see no point in complicating the last hours of these dying men with futile laparotomy. Of 52 cases of penetrating abdominal injury subjected to laparotomy at a casualty clearing station in France, 20 died, giving a recovery of 62%. Of the 20 cases which died, 9 were complicated by wounds of the thorax, 1 with a compound depressed fracture of the skull, 5 with compound fracture of the bones of the extremities or other large flesh wounds, and the remaining 5 were uncomplicated. Of the 52 cases submitted to operation, 42 were concerned with penetration of hollow viscera, including the urinary and gallbladders and ureter, and of these 42 cases, 18 died, giving a recovery in the case of damage to a hollow viscera of 58%. Of the remaining 10 cases submitted to operation, the kidney was damaged in 5, the liver in 2, the pancreas in 1, and in the remaining 2 cases, the lesion was retroperitoneal. Of 6 cases operated upon in the line and not included in this list, recovery followed in 2, both cases having suffered hemorrhage of a severe degree from a wounded spleen. The remaining 4 were concerned with extensive damage to the mesentery. We could include other urgent cases operated upon in the field ambulances in this list, but as they were only kept a very short time after operation, we cannot speak of their condition at the end of the 8th day, consequently we have not included them. Of 55 laparotomy cases met with at a base hospital in the Balkans, 41 were operated upon at the casualty clearing stations and 14 at the base hospital. Operations at casualty clearing station and reaching base hospital. Penetration of large gut, 5 cases, 1 case of resection and end-to-end anastomosis. Penetration of small gut, 23 cases. Penetration of peritoneum and solid viscera, liver and kidney, 8 cases. Penetration of ureter, 3 cases. Penetration of urinary bladder, 2 cases. Total, 41 cases, no deaths at base. Operations at base hospital. Penetration of large gut, 3 cases, 1 death, 2 recoveries. Penetration of small gut, ureter, 2 cases, 9 cases total, deaths 2, recoveries 7. Rupture of pancreas, 1 case, 1 recovery. Peritoneum and ureter, 1 case, 1 death. Total deaths 4, total recoveries 10. End of Chapter 21, Part 2.
Chapter 22 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Availle in September 2015. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 22. Burns. Burns or scalds occurring in wartime are either accidental or the result of the explosion of a bomb or high explosive shell in the immediate neighborhood of the individual concerned. We did not see a single case of a burn result from the use of the Flammenwerfer, liquid fire. Burns may vary in severity from a superficial erythema to most destructive charring. The immediate complication of a burn is shock, and the degree will vary with the area of the body surface involved. The remote complication is sepsis. 8 cases of most severe burns involving considerably more than half the surface of the body, and all resulting from the same accident, were admitted to a base hospital. All the men were burned with cordite which had caught fire in a gun pit. 5 of the 8 cases died, 2 from immediate shock, the remaining 3 from septic complications. The post-mortem findings in all those dying from septic absorption were the same. The liver, heart, and kidneys showed advanced fatty degeneration, both lungs were acutely congested, and in every case the stomach was dilated and the duodenum showed ulceration. Treatment. The burned areas should at once be protected from the air by means of sterile gauze, wool, and bandage. Brandy and other stimulants may be given and the patient removed to hospital without delay. On admission to hospital he should be put to bed, made warm, and 2 pints of saline with 1 ounce of brandy should be given subcutaneously. As soon as the pulse has improved, the patient is taken to the operating theatre and anesthetized with open ether. The burned areas are thoroughly washed with warmed normal saline solution and shaved. If the head and face have suffered, they must be shaved. The quicker the burns are cleaned and dressed, the better the patient's chances. Hence, in the case of extensive burns, 2 or more surgeons, if available, should work in conjunction. Undoubtedly one of the best dressings for burns, if they can reach a hospital early, is embrine, or its equivalent, paraffin No. 7. The burned areas, after shaving, are again carefully washed over with normal saline and dried prior to applying the dressing, with either a brush or a sprayer. We prefer the former. Spray for the treatment of burns by paraffin wax. The substance contained in this outfit is a mixture of paraffin and wax, etc. Embrine could also be used. It is solid when cold and becomes fluid when heated to 140 to 150 degrees Fahrenheit. It can be used as a first aid dressing for burns and for their subsequent treatment, if considered desirable. The originator of this method, Dr. Bart de Sandford, advocates its use for all classes of burns and employs it through the whole stage of treatment, and he claims that by so doing he has had excellent results. Methods of use. A. Heating. Place a piece of wax in the sprayer provided and heat the latter over a spirit lamp or set it in a basin containing a little water, which should be kept boiling for 10 minutes. B. Precautions to be taken. Care should be taken to prevent any water getting into the wax. It must be remembered that the latter does not burn the tissues at 176 degrees Fahrenheit, but the smallest quantity of water present would cause scalding. With the same end in view, the burnt area should be gently dried before the application is made. While the wax is being heated, prepare a few fine layers of absorbent cotton. These layers should be as thin as possible. C. The dressing. When the wax is in a liquid state and has been allowed to cool to a temperature of, roughly, from 140 to 150 degrees Fahrenheit, it can then be applied to the burnt area, either by means of the spray or the brush supplied for the purpose, or by the sprayer followed by the brush. If the sprayer is used, the metal should be heated all over, including the nozzle, as any coagulation of the wax at this point will interfere with the proper working of the instrument. The flame should be kept from the wooden handle and rubber bellows. As regards the technique, the sprayer is first held about 9 inches from the patient, and the area is sprayed over until it has the appearance of being covered with a thin layer of hoar frost. The sprayer is now brought closer, say 3 to 4 inches, and the bellows briskly worked. It will then be seen that in the center of this spray stream the wax assumes a liquid appearance. With this liquid spray the whole of the affected part is now quickly covered. A thin layer of cotton wool is next laid on this wax, and the whole is then again covered with the liquid wax by the brush. It is strongly recommended that the surgeon should first try the method by applying 2 or 3 dressings to his own hand and arm. Note: when removing the lid from the sprayer, do not hold it by the handle, as the leverage may buckle the side of the instrument. It should be held by the body of the sprayer, using a cloth if the metal is hot. When using the brush, remove the lid of the sprayer, take the brush provided and dip it in the liquid. Now spread the latter over the wound without pressing, that is, as much as possible dabbing it and not brushing it on. This operation is repeated until the glazing is complete, taking care to leave no spot uncovered. Immediately afterwards, place quickly on this first wax glaze one of the thin layers of absorbent cotton, already prepared as explained above, and then, with the same dabbing movement, put on several more applications of the fluid. If the wound is extensive, the operation is done on small square surfaces successively and close together, about 4 by 4 inches. These little squares thus become part of one another. After the preparation, which with cotton wool forms a shell or casing, has been allowed to cool, dressings and bandages can be applied in the usual manner. The initial use of the sprayer is recommended where the area is painful. Removing the dressing. For the first few days the waxen shell must not be left in place more than 24 hours. Later, if it is decided to continue the use of wax, it can be left for 48 hours or even longer. To remove the dressing, untie the bandages and expose the shell. An incision is made in the latter by means of a blunt knife or scissors, and the whole is peeled off. The wound is afterwards bathed with boiled water, and the cleansing is further perfected by washing with absorbent cotton soaked in boiled water. Then it is dried either by a current of warm air or by a piece of cotton wool, care being taken not to rub or cause the granulations to bleed. Antiseptic solutions should not be used, except very weak, and care should be taken not to apply the liquid at a temperature of more than 150 degrees Fahrenheit. Heating the wax in a bath of boiling water raises its temperature to nearly 212 degrees Fahrenheit. Therefore, before applying it to the burn with a brush, it should be removed from the water bath and allowed to stand for a minute or two, so as to reduce its temperature to below 150 degrees Fahrenheit. It is claimed for the application that 1. It immediately alleviates pain. 2. It constitutes a warm shell under which the tissues are protected against outside contamination. 3. It can be removed without pain or injury to the newly forming tissues, and thus limits the formation of scar tissue. If the burns are septic, they should be cleaned and sterilized before the application of the paraffin dressing. The quickest and most satisfactory method of bringing about sterilization is by the application of a Carrel-Dakin dressing. After giving paraffin No. 7 a considerable trial, we have arrived at the following conclusions. 1. It is the best dressing that can be applied to burns if it is applied within an hour or two of the injury. 2. The dressing is painless both in application and removal. 3. The burned surface heals and skins over with remarkable rapidity. 4. There is the minimum formation of scar tissue. 5. It is useless to apply paraffin No. 7 to septic surfaces. The surfaces must first be sterilized by the Carrel-Dakin method before the dressing is applied. Should the skin be blistered and the blisters still unopened, they should be left and the preparation applied over them. We do not recommend fomentations for cleaning up septic burns prior to applying paraffin No. 7, for Carrel's treatment has given a quicker and more satisfactory sterilization. The treatment of gunshot wounds associated with burns has already been referred to. We have now abandoned the use of older remedies in the form of picric acid, carron oil, etc., for the results obtained by paraffin No. 7 have entirely surpassed those obtained by the older methods. End of chapter 22. Chapter 23 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Availle in September 2015. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 23. Conditions Peculiar to Airmen. There are certain conditions peculiar to flying men which call for special notice. It has long been recognized that divers must descend to and ascend from the depths at which they work, gradually, in order that a state of equilibrium may become established between the increased pressure experienced in the depths and the normal atmospheric pressure. A diver first passes from the normal to a higher atmospheric pressure. A state of equilibrium is soon brought about by a rise in the blood pressure. His blood contains oxygen and carbon dioxide under a pressure proportionate to the increased pressure in his lungs. When he comes to the surface, he leaves a higher atmospheric pressure to enter the normal. The latter change must be conducted slowly and gradually, otherwise alarming symptoms may follow. These symptoms constitute the condition known as caisson disease or diver's paralysis and are described in most textbooks on medicine. The changes brought about in an airman as the result of a transfer from a denser to a rarer medium are comparable to what is observed when a bottle of soda water is opened. Air rapidly escapes and continues to escape until a state of equilibrium is established. An airman differs from a diver in that the conditions are reversed. The older flying machines climbed slowly, consequently the change from dense to rare atmosphere was comparatively gradual. Aerial warfare has, however, necessitated alterations, and today the essentials of a good machine are speed and rapid climbing powers. The present-day airman must therefore be an individual who can rapidly accommodate himself to sudden changes of pressure. The changes brought about through the transfer from a denser to a rarer medium are mainly those concerning blood pressure, though other important points have to be taken into consideration. Normally the atmospheric pressure acts directly upon all parts of the body to which it has immediate access, that is to say, skin and exposed mucous membranes, including the lungs. As the airman climbs, the atmospheric pressure decreases, while his internal pressure remains, for the time being, the same. Consequently, the vessels of the skin and of the mucous membrane fill with blood, and whereas the intake of oxygen into the lungs is less, the output of carbon dioxide for the time being is proportionally greater, consequently a temporary change in the respiratory quotient is brought about. Turgidity of the mucous membrane gives rise to buzzing in the ears and deafness, the eyes become temporarily blurred, and hemorrhage may occur from the ears, nose, and other mucous membranes. A diminished intake of oxygen may tend to drowsiness or a feeling of faintness. Such were the sensations experienced by one of us. This state of things will continue until equilibrium is established. The more flying a man accomplishes, the sooner he can accommodate himself to a rapid change from a denser to a rarer medium. In other words, he develops some sort of an immunity, if one may use the term, to a rapid change of conditions in pressure. As the airman descends, he passes from a rarer to a denser medium. This change may be brought about slowly and at leisure, or it may have to take place rapidly if the flying man is wounded. On landing, the airman feels tired, and there is a strong tendency to sleep. After 3 or 4 hours' sleep, he awakes refreshed, and there is a feeling of bien-être. Medical examination of men before entering the Royal Air Force. No branch of the service calls for a more thorough medical examination of its officers and men than the Royal Air Force. An airman must possess good eyesight, his heart must be sound, He must not be subject to fits, and above all he must be of a calm and composed disposition. Special attention must be directed towards an examination of the nose, lungs, and abdominal walls, and under no circumstances should a bleeder be admitted. Should unhealthy conditions of the nasal mucous membrane be present, such as hypertrophic rhinitis, nasal polypi, etc., these must be duly treated and put right before the man is allowed to fly. Should disease of the lung be present in the form of old tubercle which is quiescent, and especially if old cavitation exist, the man should be debarred, owing to the risk of hemoptysis while flying in a rarefied medium. The abdominal wall should be most carefully examined for hernia or large patent external abdominal rings. On more than one occasion whilst flying a hernia has come down, owing to the absence of the normal atmospheric pressure, which hitherto had been instrumental in keeping it up, and these herniae are most prone to become strangulated. Any man desirous of entering the Royal Air Force must consent to an operation for the radical cure of his hernia, or to an operation for the obliteration of a large patent abdominal ring through which a hernia, previously unrecognized, might readily descend. Varicose veins and hemorrhoids must for obvious reasons be corrected. Precautions to be taken by flying men. No man should fly who possesses a breach of any sort in his skin, owing to the risk of hemorrhage. The following cases may be quoted to illustrate this point. Lieutenant sustained a small accidental cut of his finger which bled slightly. He had a dressing applied, and as nothing further occurred, he ascended in his machine on the following day. He felt a curious sensation in one of his gloves, and inspection showed that the glove was full of blood. He descended and found that considerable hemorrhage had occurred from the small cut in his finger. Lieutenant too had a carious molar tooth extracted. 3 days later he ascended in his machine, but was compelled to land owing to a profuse hemorrhage from the tooth socket. Wounds of airmen. The immediate danger of wounds inflicted on men whilst flying is uncontrollable and rapid hemorrhage, this being due to the rarefied condition of the atmosphere. The extent of the hemorrhage will vary with the length of time the man has been flying. Thus, if an airman is hit soon after attaining a height, hemorrhage will be severe, whereas if he is wounded after a state of equilibrium has been established between his blood pressure and the rarefied atmosphere, then the hemorrhage will be less severe. As he descends rapidly after being hit, he passes into a denser medium, and when he reaches normal atmospheric pressure, the hemorrhage often stops altogether. Should the wound be at all extensive, another complication akin to surgical emphysema arises as he passes from a rarer into a denser atmosphere. Thus we saw one case of a wounded airman who had been hit in the thigh. The thigh was tympanitic, the tissues being charged with air. Curious as it may seem, an airman's wounds are frequently infected, and this can be explained only by the clothes. He may be wounded by shell or by machine gun bullets from an enemy aeroplane. The latter bullets differ from those used by the German infantry in that they are of two kinds, armor-piercing and explosive. It would seem that infection of wounds might be obviated in the case of airmen if by some means or other their clothes could be sterilized before a flight. Treatment. The actual treatment of airmen's wounds does not differ in any way from that employed for other wounded men. There are certain precautions, however, to be taken. When a wounded man lands, he should have his wounds carefully dressed, and he should be kept quiet for at least 2 or 3 hours. There is a great risk in operating immediately upon a wounded airman before the necessary state of equilibrium has become established. After an interval of 2 or 3 hours of landing, he may safely be moved to a casualty clearing station where his wounds can be surgically treated. End of chapter 23.
Chapter 24 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Reading by Matt Perard. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 24, Wounds of the Arteries and Peripheral Nerves. A wound involving an artery may result in contusion, perforation, or complete division of the vessel. An artery may be contused as the result of a direct blow or through a fragment of a fractured bone being driven against it. The latter phenomenon is by no means uncommon in connection with fracture of the long bones. Perforation is usually effected by small pieces of missile, usually bomb fragments. Perforation of an artery, the result of a rifle or machine gun bullet, has been a rare event during the present war. The artery may be perforated in such a way that there is a separate wound of entry and exit in its walls, or the entry and exit wounds may be blended into one cavity. Complete division of an artery is usually the result of high explosive, and is but one part of a large lacerated wound. It occurs most frequently when a limb is either blown or torn away from the trunk. The artery may be either cleanly divided, or a large piece of its continuity may be missing. The vein may or may not be damaged, and the same applies to the nerve. Similarly, the nerve or vein may sustain injury, while the artery escapes. A contusion of an artery may subside and the artery continue to function if it be put under the best conditions. Thus, if it forms part of a general contusion resulting from a blow which has not caused an open wound, then rest is all that is required. It may happen, however, that a contusion caused under these circumstances has resulted in severe damage to the artery wall, and consequently an aneurysm may follow in due course. If the contusion is due to the presence of a missile or of a fractured bone which is driven against the artery wall, the missile must be removed at once and the fractured end of the bone drawn back into position. Primary hemorrhage. Should the artery be perforated or completely divided, primary hemorrhage will result. Primary hemorrhage, as a rule, is not immediate if an artery is completely severed. On the other hand, it is immediate if the artery is buttonholed, for in the latter case the muscular coats of the artery as a whole can neither contract nor retract. The breach in the artery wall is therefore kept patent by a muscular contraction and retraction of the undamaged part of the artery wall, and hemorrhage results. Hemorrhage may be either visible or concealed. Visible hemorrhage occurs from open lacerated wounds or from larger penetrating wounds in which the damaged artery is fairly superficial. Concealed hemorrhage occurs as the result of wounds involving closed cavities, such as the abdomen, thorax, and head. Concealed hemorrhage may, however, occur in such situations as the extremities and root of the neck. In the latter cases, the hemorrhage is usually the result of a very small missile. Thus, it is not uncommon to see an acutely tense and swollen thigh, or a tense swelling at the root of the neck, giving rise to dyspnea and dysphagia associated with an extremely minute wound of entry in the skin. Primary hemorrhage occasions shock and severely lowers the general resistance to infection. Consequently, wounds associated with primary hemorrhage of a severe degree usually become grossly infected, and both septicemia and secondary hemorrhage are prone to follow. The wounds sterilize slowly, and the patient is severely handicapped. Hence, the importance of arresting hemorrhage at once. Many cases of primary hemorrhage, whether visible or concealed, are immediately fatal, and the patients die in the line. Cases of concealed hemorrhage, occurring in such situations as the extremities or about the root of the neck, vary as to their subsequent history. If the wounded part, take for instance the thigh, is put at rest and elevated, the swelling may subside, and infection of the extravasated blood clot may not follow. The skin becomes discolored through the presence of changed blood, and there is usually little pain. Later, the generalized swelling of the limb is replaced by a localized swelling, over which a bruit can be felt and heard. The localized swelling has a pulsating and expansile impulse. In other words, a traumatic aneurysm has formed. Traumatic aneurysm is not infrequent, and the most common sites have been 1. The root of the neck, subclavian aneurysm; 2. The axilla; 3. The brachial artery at the junction of the middle and upper thirds of the upper arm; 4. The femoral artery in its middle third; 5. Popliteal artery; 6. The intracranial portion of the internal carotid artery. 2 cases. The nature of the aneurysm may be aneurysmal varix, A. Aneurysmal varix; B. Varicose aneurysm; C. False aneurysm. Aneurysmal varix can occur only when both artery and vein have been wounded. The two perforations adhere, and a true direct communication between artery and vein results. This type of aneurysm is rare. Varicose aneurysm can occur only when both artery and vein have been injured, the communication between artery and vein in this case being established by means of a channel. This type of aneurysm, again, is rare in connection with war wounds. By far the most common is the false aneurysm. This usually follows as the result of a small perforation of an artery. Blood escapes into the tissues, and the extent of the leak becomes limited and circumscribed. Around the circumscribed clot, an envelope of fibrous tissue forms, and a false sac results, which communicates with the breach in the artery. The formation of the sac may occur as early as 48 hours after injury, or it may be delayed as long as a fortnight. We saw one case at a casualty clearing station in which a pulsatile swelling had formed in the axilla 36 hours after injury, but those cases in which the popliteal, femoral, and brachial arteries were involved were only discernible on about the 10th to the 14th day. Examples are the following. Case 1. Private S., wounded on April 24, 1917, in the Balkans, was admitted to hospital with a swelling of the left side of his neck just below the lobule of the ear. There was a minute wound of entry over the swelling, about twice the size of a large pin's head. He complained of difficulty in swallowing. On April 26 he coughed up a little blood, and with it a minute piece of high explosive, a fragment of a hand grenade. On April 28 his swallowing was easier, and he felt better and suffered less pain. On April 30 the swelling was subsiding, but he complained of buzzing noises in his head. On May 4, i.e., 10 days after injury, there was a circumscribed swelling below the lobule of the left ear about the size of a small tangerine orange, with a pulsatile impulse and a bruit to be felt over it. Case 2. Private was admitted to hospital in the Balkans on April 26, 1917, having sustained a wound of his left thigh. The thigh was acutely swollen and somewhat tender, and very small wounds of entry and exit were situated in its middle third. The circulation in the foot was good. The limb was immobilized and elevated. 4 days later the swelling was subsiding and the limb was yellow in color owing to the presence of altered blood. On the 9th day following injury a pulsatile swelling appeared in the middle third of the thigh in the course of the superficial femoral artery as it lay in Hunter's Canal. Case 3. Lieutenant was admitted to a base hospital in the Balkans on the 4th day after receiving his wound. He had sustained a very small wound of entry at the root of the left side of his neck. On admission, there was a diffuse swelling in the left infraclavicular fossa. The swelling subsided and was replaced on the 11th day by a pulsatile tumor. Case 4. Private was wounded by a piece of high explosive which entered his right eye. The eye was destroyed and removed. On the 6th day following injury, he developed a pulsating exophthalmos of the sound eye. Treatment. The treatment of visible primary hemorrhage should be its immediate arrest. Stretcher bearers and combatants alike should be instructed how to arrest hemorrhage. In the absence of the medical officer, we adopted the following simple plan in the line, which worked very satisfactorily. A putty was tied around the limb above the hemorrhage, and was screwed up tightly by means of a stick or entrenching tool handle until hemorrhage was arrested. The extemporized tourniquet was kept on until the medical officer arrived, when it was removed. The bleeding vessel was then picked up with Spencer-Wells forceps and ligatured. Cases in which hemorrhage was concealed in such situations as the limbs or the root of the neck were treated by thorough immobilization and elevation of the part, with a half grain of morphia given hypodermically. Treatment at the casualty clearing station should be that already recommended for lacerated wounds, namely excision and sterilization. If severe primary hemorrhage has already occurred on the battlefield, most stringent measures must be taken to remove all dead and infected tissue, and every energy directed towards sterilization of the wound after excision, as these patients possess but little resistance to infection, and secondary hemorrhage is very apt to occur if the wound after excision again becomes infected to any considerable degree. It is quite justifiable and better practice to wait in cases which show concealed hemorrhage in such situations as the limbs and root of the neck. We are convinced on this point, as we have now been concerned in many of these cases and have seen the results of immediate and delayed operation. The result of waiting is usually the formation of a false aneurysm. If a large artery is involved, the collateral circulation has a chance of establishing itself. The extravasated blood is in great part absorbed, and there is far less risk of hemorrhage in late than in early operation. These cases rarely become infected, and without exception the swelling in the limb from extravasated blood has subsided and never caused serious interference with the circulation in the part of the limb below the lesion. The difficulties of early operation in cases of concealed hemorrhage are well known to surgeons who have worked at a casualty clearing station. Appalling hemorrhages have resulted while operating upon wounds about the neck, and on more than one occasion the patient has died on the operating table. Equally difficult and tedious at this stage are operations for ligature of the posterior tibial artery, the interosseous arteries of the forearm, etc. The wounds occasioned by the operation are very prone to become infected, and too often a secondary hemorrhage follows. We therefore strongly recommend immobilization of the limb and the adoption of the principle of wait and see, for we can speak from the results of both methods of treatment. Treatment of aneurysm. Aneurysmal varix and varicose aneurysm must be treated by excision. The different operations are described in most surgical textbooks and need not be repeated here. We have always, employed the method of complete excision, and have not had recourse to proximal or distal ligature, or the methods recommended by Medas. It is important to be sure that the peripheral circulation is adequate before excision is performed, and we have usually employed proximal compression of the affected artery for a few days prior to operation. False aneurysms show a marked tendency to spontaneous cure. This has frequently happened. Consequently, the surgeon should not be in a hurry to operate. The false sac gets gradually smaller, and in a number of cases eventually becomes obliterated. Two cases of aneurysm of the intracranial part of the internal carotid artery took this course. Case 1, quoted above, on leaving hospital for England, showed a small tumor that was steadily getting less, and we have seen spontaneous cure occur in a number of cases of false aneurysm affecting the large arteries of the limbs. Should the aneurysm persist, be causing pain, or show signs of increasing in size, it should be removed by complete excision. We have now performed 10 operations for excision of false aneurysm, all healed by primary union, and in no case did gangrene follow. The important point in the conservative treatment of false aneurysm is absolute immobilization of the part. If the limb be allowed to move, there is not only the risk of emboli to be feared, but the false sac may get larger and suddenly rupture. Should the aneurysm be pressing on nerves and causing pain, proximal pressure should be given a fair trial before excision is decided upon. Wounds of the peripheral nerves. Wounds of the peripheral nerves are either contusions, lacerations, or partial or complete divisions. A nerve may be injured at any point in its continuity, and upon the particular point implicated will depend the incapacity. Injuries of nerves often accompany injuries of the large arteries and veins, and a lacerated wound involving a large area of skin and fascia will implicate any cutaneous nerves which normally lie within the wounded area. Large lacerated wounds which have been allowed to heal by granulation often incorporate cutaneous nerves in the scar tissue, causing much pain and suffering, and nerve trunks may become involved in the scar tissue of a deep wound which has been allowed to granulate, or in the callus of a uniting fracture, thus causing paralysis of the muscle it supplies and loss of sensation in the areas of skin to which it is distributed. The nerves that will be referred to are those which mostly concern the orthopedic surgeon, and injury of which is associated with the greatest degree of disability. These are the nerves of the extremities. Nerve energy may or may not be associated with pain or acute hyperesthesia in the area which the nerve supplies. Pain has been frequently found to be associated with a partial tearing or a complete penetration of the nerve trunk. One case associated with a partial division of the sciatic nerve had constant pain of a burning and stinging kind, alternating with pain shooting from the foot up the limb. The skin of the toes and foot became shiny and showed trophic changes. The pain was so intense and continuous that it became unbearable, and the patient started to go downhill for want of sleep. The sciatic nerve was exposed through an incision over the wound, when the nature of the lesion was discovered. The proximal end of the nerve, where it had been partially divided, was swollen and bulbous. The nerve was cleanly divided, the bulbous enlargement was excised, and the divided ends sutured. The relief of pain was immediate, and the wound healed per primum. The patient was heard of 1 year later, and he reported some slight amount of sensation and movement in the parts concerned. Similar symptoms occurred in another patient who had been wounded in the forearm. Intense and unbearable pain persisted in the hand and forearm, which prevented sleep. The median nerve was exposed, and found to be cleanly penetrated. A small piece of the nerve, including the wound, was excised and suture performed. Relief of pain was complete. The wound healed per primum, but we were unable to trace this patient after the 6th month following operation. At this date there was no return of sensation. Many wounds implicating nerves, on the other hand, give rise to complete anesthesia and analgesia in the parts of the skin they supply. The areas of anesthesia and analgesia usually correspond to those supplied by the particular nerve involved, but occasionally the anesthesia is of the sleeve variety. This is well illustrated in the case illustrated. See Figure 351. This particular patient showed the reaction of degeneration on 2 successive occasions in the muscles supplied by the musculospinal nerve. On exposing the nerve, it was found that its continuity was not destroyed, and it appeared to the naked eye normal. Recovery followed 10 weeks after injury. Paralysis of the muscles supplied by an injured nerve, with loss of sensation in the classical areas of skin supplied by the nerve, may be present, and yet the continuity of the nerve may not be in any way destroyed. This phenomenon is shown in the case illustrated. See Figures 353, 354. In this particular case, although the reaction of degeneration was present in the muscles supplied by the ulnar nerves, yet to the naked eye the nerve appeared normal when exposed. Recovery followed 3 months after injury. The brachial plexus may be damaged as the result of gunshot wounds about the root of the neck. The nerve trunks most frequently involved are those of the 5th and 6th cervical. The symptoms are those of praxial palsy, (ERB), with paralysis and wasting of the deltoid. See Figure 355. The musculospiral nerve may be damaged either directly by a missile or as a complication of a fracture involving the shaft of the humerus. Wrist drop is the important sequel. See Figure 352. The ulnar nerve may be injured as the result of wounds of the arm or forearm. A typical case is illustrated in Figures 353 and 354. The median nerve may be injured in the upper arm, forearm, or at the wrist. See Figures 356, 357. The sciatic nerve may be implicated in any wound involving the buttock or thigh. A typical case is shown in Figure 359. The external popliteal nerve. Damage to this nerve usually complicates wounds involving the neck of the fibula, the knee joint, or the thigh. See case illustrated by Figures 360, 361. Drop foot is a result of injury to the external popliteal or anterior tibial nerve. The posterior tibial nerve is most frequently damaged in the part of its course below the malleolus of the tibia. It is rarely injured in the calf of the leg. An injury of the great auricular and spinal accessory nerves is shown in Figure 363. Treatment. Nerves that in lacerated wounds are seen to be divided should be sutured at the time that the wound in the soft parts is excised. If this is impossible owing to destruction of a considerable portion of its continuity, then the gap should be bridged with a few strands of catgut. It is useless to attempt approximation of the divided ends of a nerve, when there has been loss in its continuity so long as the wound is infected. Hence sterilization of the wound and secondary suture should be the surgeon's first aim, leaving any subsequent operation on the nerve until later, when the wound is healed with a minimum amount of scar tissue. Small perforating wounds of the extremities which are followed by paralysis of nerves call for expectant treatment, although the reaction of degeneration and a classical anesthesia be present in the muscles and skin supplied by the nerve. Too often, at operation, nerves apparently divided have been found to be intact, and restoration of function has followed within an interval of 3 months. For cases such as these, Massage and electrical treatment should be employed, after the correction of any obvious deformity in the shape of dropped wrist or dropped foot, for 4 or 5 months. If at the end of this time the symptoms still persist, then it is justifiable to cut down on the injured nerve and investigate the damage done. Perforating wounds of nerves associated with pain which disturbs sleep and trophic changes in the skin require operative treatment, and this has been referred to already. End of chapter 24.
Chapter 25 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 25, Amputations. Amputation is called for under the following conditions. 1. Hopeless mutilation of any part of a limb involving irreparable damage to bone, vessels, and nerves. 2. Acute spreading gas gangrene. 3. Wounds of the extremities, especially those implicating bone and joint cavities, in which septicemia is either threatening or has become established. 4. Repeated secondary hemorrhage. 5. Wounds involving such excessive loss of continuity in a bone as will leave a flail and useless limb. 6. Gangrene other than gas gangrene resulting from any cause. Limbs that are hopelessly mutilated are beyond human aid, and amputation is inevitable. Amputations for conditions resulting from sepsis have been numerous in the past. Today it seems that the tide is turning, for amputation has become far less frequent since early excision of the wound followed by an efficient sterilization has been practiced. Today many limbs are saved that 18 months ago would, without hesitation, have been submitted to immediate amputation. Success in these cases undoubtedly lies in early excision and rapid sterilization of the wound, and we have found no more satisfactory method of accomplishing this than that recommended by Carrel and Dakin. A single series of 109 cases of amputation include 32 performed at a casualty clearing station and 77 at a base hospital in the East. Of the 32 performed at the clearing station, 20 were concerned with the lower extremity and 12 with the upper extremity. Amputation was necessitated by 1. Irretrievable damage of large vessels, bone, and nerves. 2. Extensive mutilation of soft structures. 3. Gangrene. 77 amputations performed at a base hospital include 1. Compound fracture of the pelvis with severe comminution of the upper third of the femur, 1 case. 2. Advanced gas infection of the thigh, 14 cases. 3. Gangrene of the leg with extensive comminution of bone, 12 cases. 4. Irreparable damage of the tarsus with gangrene of the foot, 3 cases. 5. Disarticulation at the hip joint for gangrene, 5 cases. 6. Gunshot wounds of the knee joint, 15 cases. 7. Gunshot wounds of ankle and tarsal joints with severe comminution of bone, 5 cases. 8. Gangrene of the upper arm requiring disarticulation at the shoulder joint, 5 cases. 9. Compound comminution of forearm, carpus, and metacarpus, 4 cases. 10. 13 cases of amputation transferred from other hospitals, 13 cases, with a total of 77 cases. Choice of operation. When amputation is inevitable, the choice of operation must be governed by circumstances. It is rarely possible to perform the classical amputations recommended in textbooks, as so few cases are suitable. Experience gained at a busy casualty clearing station in France suggested the following conclusions. 1. If a wounded man is very collapsed as a result of shock and hemorrhage, and if immediate amputation is necessary, a flush or guillotine amputation should be performed, if possible, through healthy tissue. If this is impossible, it must be conducted through infected tissue. The method has two advantages in that it a. is rapid and causes the minimum of shock, and can, if necessary, be performed under nitrous oxide and oxygen anesthesia. b. leaves the minimum surface of exposure for infection and septic absorption. It possesses the disadvantages of leaving an open amputation stump and the necessity of a higher amputation later on. The ends of the divided nerve trunks are apt to be left exposed, as is also the ligatured end of the artery. 2. If time permits and the patient's condition warrants it, and especially if the amputation can be performed through apparently sound tissue, then flaps can be fashioned from whatever tissue is available. If possible, equal and long anterior and posterior flaps are preferable. After thoroughly cleaning and shaving the skin, a tourniquet is applied. Long anterior and posterior skin flaps are now fashioned and reflected. A guillotine division of the muscles is next performed, and both muscle and periosteum are retracted. The bone is next sawn through, and the amputated limb removed. The cuff of periosteum is next stitched over the divided end of the bone, and all divided vessels ligatured. The main artery should be secured with a double ligature, and the nerve trunks drawn down and cut short. The muscles are approximated by 1 or 2 sutures of catgut to obliterate all dead space, and the skin is finally sutured with silkworm gut. Throughout the operation, the wound surface is swabbed with flavine, and before applying the dressing, 3 or 4 drachms of flavine, strength 1 to 1,000, are injected between the sutures in the skin into the tissues of the stump. A dressing and splint are then applied, and the patient returned to bed with the stump elevated. If the amputation has to be performed through infected tissue, the flaps are stitched widely open and a Carrel's dressing applied. As soon as the stump is sterile, secondary suture is performed. We have now performed a number of amputations through infected tissue and have closed the stump by suturing the flaps over Carrel's tubes. 2-hourly installation of the antiseptic, hypochlorite, has been carried out, and in the majority of cases, the stump has healed by primary union. We would recommend this procedure at the field ambulances for cases in which operation can be undertaken at an earlier date following injury, and consequently at a time when infection is slight and limited to the tissues of the wound. This will not only save time and expenditure of labor and dressings, but it will also save the patient much pain and a second operation later on for closing the stump. Amputations performed in the trenches, at the field ambulances, or the advanced dressing stations usually consist in dividing the remaining muscles or tendons which still hold the limb on. Many cases arriving at a casualty clearing station are in a most profound condition of shock and collapse, resulting from hemorrhage or from the imperfect immobilization of the wounded limb during transport and the consequent pain. The shock occasioned by a compound comminuated fracture of the femur is well known, but if in addition to the fracture there is a superadded virulent infection of the soft parts, together with the unavoidable shaking during transport, the general condition of patients so afflicted by the time they reach the casualty clearing station is often desperate. Hence it is easy to realize the number of guillotine amputations must reach a base hospital. Subsequent history of open amputation stumps. All open amputation stumps are infected from the beginning. Hence it is of the utmost importance to start their sterilization at once. A Carrel-Dakin dressing should be applied immediately the amputation is completed. Guillotine amputation stumps are exceedingly prone to secondary hemorrhage, as the ligatures on the main vessels, if the stump is infected, hold only for a very short time. Secondary hemorrhage has occurred as early as the 5th day, and as late as the 12th day after the amputation has been performed. Secondary hemorrhage and its treatment have already been referred to. We recommend anterior and posterior flaps for all amputations whenever they can be conveniently fashioned, but the surgeon must be prepared to make use of whatever flap he can get. Amputations through the upper arm are quickly and easily performed by the circulation cuff amputation. It is always advisable to apply extension to open amputation stumps at the earliest possible time in order to prevent retraction of the soft parts. Secondary suture of open amputation stumps. Secondary suture in the case of guillotine amputation stumps is a difficult procedure because 1. Muscles and skin have become retracted. 2. The smaller arteries in the muscles of the stump are both numerous and enlarged, rendering reamputation difficult. 3. There is always septic sequestration going on in the divided end of the bone. Retraction of the skin can in great part be prevented by extension applied to the skin of the stump during sterilization. Whenever possible, we have waited until the sequestrum from the end of the bone has separated naturally before performing secondary suture, and this occurs from the 4th to the 5th week after the amputation has been performed. When the stump is sterile and the sequestrum has separated, the soft parts are pushed back and separated subperiostally from the bone. A piece of bone is removed of sufficient length to allow the skin to meet over it. If extension has been applied to the stump from the beginning, this is usually possible. If, on the other hand, the skin has retracted, then reamputation with removal of more muscle must be undertaken. The stump is now sutured, and 1 or 2 Carrel tubes are included. If at the primary operation skin flaps have been fashioned and stitched back, removal of the bone is all that is required. It is important to make the skin flaps as long as possible at the primary operation. The sutures are removed at the end of the 10th or 12th day, and the patient may get up at the end of a fortnight. When guillotine amputation has been performed, there may be considerable tension in the skin sutures. We have in this connection used the method advocated by Major Chappell, wherein the tension sutures are inserted through buttons or pieces of rubber tubing placed parallel to the line of suture. By this means, not only the tension on the approximating stitches is relieved, but all dead space in the stump is obliterated. In all cases requiring amputation, conservatism must, of course, be practiced and the greatest length of stump left. Symes amputation and amputations performed through the knee joint have not proved a universal success in connection with war wounds. Flush amputation through the knee joint for severe wounds of the leg in desperate cases is a rapid procedure, for there are only the popliteal and sural vessels to ligature. Secondary suture in these cases is simpler and can be undertaken earlier. The patella should always be removed at the primary operation. End of chapter 25. Chapter 26 of War Surgery from Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery from Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 26. Gunshot Injuries of the Spine. The spine may be injured as the result of wounds involving 1. The perivertebral soft structures only. 2. The perivertebral structures and vertebrae. 3. The perivertebral structures, vertebrae, and spinal cord. Gunshot wounds of the perivertebral soft structures only may give rise to symptoms of injury of the spinal cord, and as a result of such wounds, hemorrhage of varying degree has not infrequently occurred within the spinal column. The more common sequel, however, to injuries of this kind is a state of spinal concussion, although this latter condition may become established in the absence of any visible wound, through such an event as the burst of a shell in the immediate vicinity of the individual affected. Symptoms may range from paresis to complete paralysis, and often associated with them are psychic phenomena. Instances of this kind are true cases of shell concussion, and they must not be confounded with that heterogeneous collection of cases, showing a diverse variety of symptoms which were formerly grouped under the title of shell shock. Some authorities will deny that psychic neuroses and wounds can coexist in the same individual, or that even a true spinal concussion can be complicated by psychic phenomena. This has not been our experience either in the line or at the casualty clearing station. We admit that while coexistence of the two conditions in the same individual is comparatively rare, yet in an appreciable percentage of cases they do occur together. One instance may be quoted. Lieutenant Blank, during an engagement, was hit in the leg. He was brought to the regimental aid post. His wound was dressed, and he was put on a stretcher to await evacuation. During this time, other wounded were receiving attention, there was considerable disturbance going on outside, and shells were bursting nearby. This officer, despite the severity of his wound, suddenly got up, protested murder, drew his revolver, and threatened to shoot everybody in the dugout. He had to be forcibly restrained and tied to his stretcher. Half a grain of morphia was administered hypodermically, and his evacuation from the line was carried out as soon as the shelling had ceased. 3 months later, he was still undergoing treatment for the psychic condition and was reported to be improving. This is but one example of many which came under our care while in trenches. Wounds involving perivertebral structures and vertebrae may occur in the absence of injury to the spinal cord. Damage to the vertebral column may consist in fracture of the transverse processes, the spinous processes, the laminae, or the bodies of one or more vertebrae. It is not of rare occurrence to see a missile lodged in the body of a vertebrae without giving rise to symptoms of cord injury. Fracture of the spinous processes is not uncommon. Fracture of the laminae is usually associated with symptoms of pressure upon the spinal cord, while fracture of the transverse processes may implicate either the nerve roots or the nerve trunks as they emerge from the intervertebral foramina. Fracture of the transverse processes of the cervical vertebrae is apt to be complicated by injury of such important structures as the vertebral artery and vein, the nerve trunks of the brachial plexus, or of the fourth cervical phrenic nerve. Severe hemorrhage which is difficult of control may take place from wounds in this region, while paralysis of the diaphragm as a result of injury of the phrenic nerve is an exceedingly grave complication. The spinal cord may be injured as the result of 1. Pressure exerted upon it by a missile or a depressed piece of bone. 2. Pressure exerted upon it by an extrathecal or an intrathecal hemorrhage. 3. Partial or complete division of the cord by the missile. Wounds involving the cord may range from small penetrations or perforations to wounds of the most ghastly description. Fortunately, many of the more severe cases die a painless death in the line. Apart from their terrible nature, these wounds have presented some points of interest. The following are one or two examples. Case A. Private Blank was completely decapitated by a trench mortar, the body being flung over the parapet by the force of the explosion, whilst the head remained in the trench bottom. An examination almost directly after it had happened showed conjugate deviation of the eyes to the right. There was a coarse irregular nystagmus. The facial muscles were twitching, and the corneal reflex was present. The light reflex was not tried. The twitchings of the facial muscles persisted after the corneal reflex had disappeared, which, as far as we could reckon, was about 3 minutes after decapitation. Case B. Private Blank was completely cut across at the level of the second or third dorsal vertebra by a large piece of high explosive shell shaped like a knife blade, longer than the blade of an ordinary bread knife and much heavier. The same phenomena was observed in the face and eyes. Examination of the trunk showed the knee jerks to be present and distinctly brisk. Pinching the inner side of the thigh caused the corresponding leg to be drawn up, and both urine and feces were voided. Owing to circumstances, the plantar response was not tested, neither was the presence or absence of ankle clonus ascertained. Case C. Private Blank was wounded by a piece of high explosive shell which carried away a large portion of his back in the middle dorsal region. The spinal column and cord were mushed. No other word describes the condition. Over an extent of about 3 vertebrae, and there was severe and uncontrollable hemorrhage taking place. To all appearances, the man was dead, for there was no attempt at voluntary movement above the lesion and respiration had ceased. An examination directly after the injury showed exactly the same findings as in Case B. It seems, therefore, that a complete lesion of the spinal cord is not followed immediately by loss of the deep reflexes, and that accessory centers are probably present in the cord, allowing of muscular response to cutaneous stimuli. We regret that circumstances did not permit of investigation of the plantar response and ankle clonus. Wounds of the spine in the dorsal and lumbar regions may be complicated by injury of the thoracic or abdominal viscera. If the thorax is involved, the lungs, heart, or great vessels may be wounded. An injury of the heart or the great vessels is practically always rapidly fatal. Wounds of the lung under these circumstances are usually severe, as spicules of bone are apt to be carried forward by the missile into its substance, so causing a greater degree of laceration. If the wound involves the abdomen, any of the abdominal viscera may be implicated, though perhaps the most common in this connection are the kidneys. If the aorta or any of the larger vessels are wounded, death usually follows rapidly, hence these cases rarely leave the battlefield. The spine, on the other hand, may be injured by a missile which first enters the abdominal or thoracic cavities, and this event has already been referred to in other chapters dealing with wounds of the thorax and abdomen. Lastly, wounds of the spine may be complicated by multiple wounds elsewhere. Diagnosis. An early and correct diagnosis of the nature of the injury is essential. The main points to consider are: 1. The presence or absence of a visible wound. 2. The condition of the motor and sensory functions in the parts below the lesion immediately after the wound has been inflicted. 3. The level of the zone of hyperesthesia. 4. The condition of the sphincters. 5. The effect of lumbar puncture on the symptoms and the character of the cerebrospinal fluid. 6. The result of a skiogram taken in 2 directions to show the position of the missile and the nature and extent of the damage to bone. The regimental medical officer can be of the greatest possible assistance in giving a very brief account of the wounded man's condition directly after he is hit, because it is extremely important to know whether loss of sensation and voluntary movement below the lesion was instantaneous, or whether an interval of time existed, however short, in which sensation of any kind was present or voluntary movement possible. For by the time the patient reaches a casualty clearing station, both paraplegia and paranesthesia may be complete. Information furnished by the early condition of the reflexes is of little use in the diagnosis of spinal injury. The level of the zone of hyperesthesia will furnish information as to which segment of the spinal cord is involved. Paralysis of the sphincters, especially the deep sphincter ani, usually points to a definite lesion of the cord, though the sphincters may become temporarily paresed in cases of severe spinal concussion. Lumbar puncture will show: 1. Whether the cerebrospinal fluid is under tension. 2. Whether the fluid is clear, blood-stained, or purulent. 3. Whether its evacuation brings about any change in the symptoms. An X-ray will show the presence of a missile or a depressed piece of bone pressing upon the cord. Spinal concussion. Paresis of the limbs with headache and perhaps vomiting, inability to urinate, necessitating the use of a catheter, the presence or absence of psychic phenomena, a slow pulse, and subnormal temperature occurring in the absence of an open wound point strongly to a condition of spinal concussion. A lumbar puncture showing clear cerebrospinal fluid under tension will help to confirm the diagnosis, and with relief of the pressure, there is almost invariably an immediate relief of the symptoms. Paraplegia. Complete paralysis with anesthesia of the parts below the lesion may be due to pressure exerted on the cord either by a hemorrhage or by a foreign body in the shape of a missile or depressed piece of bone, or to a partial or complete division of the cord. It is in cases such as these that the early history is so valuable. If an interval of time did exist after the reception of the wound in which the wounded man possessed sensation and a degree of voluntary movement in the parts of the body below the lesion, then either hemorrhage or pressure exerted on the cord by a foreign body are the two possibilities. In the case of hemorrhage, the zone of hyperesthesia is not well defined. In fact, it may be so indefinite as to hardly exist, whereas anesthesia or paresthesia may extend to a higher level than that denoted by the injury. A lumbar puncture will reveal the presence of blood in the cerebrospinal fluid, and its removal will often cause an amelioration of the symptoms, especially those relating to the sphincters. Both intrathecal and extrathecal hemorrhage are usually associated with a rise of temperature and a slight increase in the pulse rate. There is usually spasticity of the muscles below the site of injury. Paraplegia, the result of pressure exerted on the cord by a foreign body, either in the form of a missile or a depressed fragment of bone, follows rapidly after the infliction of the injury. There is usually a definite zone of hyperesthesia, paralysis and anesthesia of the parts of the body below the lesion, with involvement of the sphincters, may or may not be complete, and symptoms are not relieved by lumbar puncture. Lumbar puncture may or may not show the cerebrospinal fluid to be blood-stained, but it is always under increased tension, and an X-ray will confirm the nature of the damage done. In the absence of complete paralysis, there is spasticity in the muscles of the part of the body below the lesion, and this will depend in extent upon the degree of pressure exerted on the cord. Paraplegia due to partial or complete division of the cord is complete from the beginning, and there is a well-marked zone of hyperesthesia. The muscles of the part of the body below the lesion are flaccid, and there is complete loss of sphincter control. If the lesion be high up in the dorsal region, then abdominal distension and preapsism may be present, though preapsism is not uncommon in lesions involving the lower dorsal and upper lumbar segments. Should loss of sphincter control with complete paralysis and loss of sensation of the parts of the body below the lesion be complicated by abdominal distension and preapsism, the prognosis is extremely grave. Complications. Immediate. 1. Osteomyelitis of the vertebrae affected. 2. Spinal meningitis. 3. Acute myelitis of the cord. 4. Retention of urine. Remote. 1. Trophic phenomena in the form of pressure sores affecting the skin below the lesion. 2. Cystitis, pyelitis, and pyelonephritis. 3. Incontinence of both feces and urine. Osteomyelitis of the injured vertebrae has been of rare occurrence. Should it occur, however, the large veins both within and immediately without the spinal column, dorsal spinous venous plexus, become thrombosed, septic emboli become detached, and septicemia or pyemia follow. Infection may spread to the cord, giving rise to a condition of acute myelitis or spinal meningitis. Spinal meningitis and myelitis occur as the result of the spread of infection from the wound to the meninges and cord. The pathology is the same as that of meningitis and encephalitis, complicating penetrating wounds of the head. The subarachnoid space of the cord tends to be cut off by adhesions from the wound in the meninges, and thus the arrest of a general infection of the meninges may be effected. When once a general infection of the meninges is established, spasticity of the limbs occurs, with retraction of the head and rigidity of the muscles of the back of the neck. Kernig's sign is early present. As the infection spreads upwards, the basal meninges become involved. Vomiting, headache, and optic neuritis occur, and a squint may develop. The pulse becomes rapid and irregular, fever is present, and the patient dies comatose. An examination of the cerebrospinal fluid before death shows turbidity, and the microscope will reveal the presence of the fluid of pus and organisms. Retention of urine. This is a most constant accompaniment of all spinal injuries, and calls for the use of a catheter 6-hourly. Trophic sores occur at all points subjected to pressure, and in this connection most commonly affect the skin covering the sacrum, the great trochanters, and the heels. They may attain large dimensions, and, owing to the incontinent condition of the patient, they are practically always infected. Hence there is a degree of superadded toxemia. Cystitis and pyelitis, when once established, are extremely grave complications and are often the immediate cause of death. Treatment. A. On the battlefield. There is no actual treatment beyond dressing the wound to be undertaken here. The patient should be placed on a stretcher with a couple of blankets beneath him and removed to the field ambulance with the least possible delay. A short note should accompany him, recording the presence or absence of sensation or voluntary movement directly after injury in the parts of the body below the lesion. B. At the field ambulance. All clothing should be removed and a pajama suit with bed socks substituted. The patient should be laid on a stretcher with a soft mattress beneath him, in order to diminish pressure on and bumping of the paralyzed parts during transit to the casualty clearing station. A catheter should be passed, if necessary, before he leaves this unit, and this must be carried out under the strictest aseptic precautions and the time noted on the field card. Short notes as to the presence or absence of sensation and voluntary movements in the parts below the injury should be entered on the field card, and this should be attached to the notes of the regimental medical officer. After administration of anti-tetanic serum, the patient should be given 20 grams of urotropine by mouth and evacuated without delay to the casualty clearing station. C. At the casualty clearing station. If there is a rush of work at this unit, it is inadvisable to attempt to deal with these cases. As a rule, there are operations in progress on highly infected wounds. There are many more urgent cases waiting for operation at the time, and the nursing and necessary attention that these patients require cannot be adequately given at this unit. Hence, if possible, their immediate evacuation to the base is in every way desirable. Urotropine should be administered by mouth. A short note as to the condition of sensation and voluntary movements in the parts below the lesion should be made, and affixed to those of the regimental medical officer and field ambulance. A catheter should be passed and the urine drawn off immediately before evacuation to the base, and the patient should travel on a stretcher with a soft mattress beneath him. D. At the base hospital. After an X-ray has been taken, the patient is at once put on a water bed. An examination is now undertaken to ascertain the presence or absence of sensation and voluntary movements in the parts below the lesion, and the level of the zone of hyperesthesia. The result of this examination is carefully compared with the notes of the regimental medical officer, the field ambulance, and the casualty clearing station. Nothing has so far been mentioned about the state of the reflexes, as in the early stages following a wound of the spine they are both variable and unreliable. By the time the patient reaches the base hospital, they are usually established and are of assistance. An extensor plantar response, with the presence of ankle clonus, spasticity, and exaggeration of the deep reflexes, point to organic injury of the cord. loss of the deep reflexes, total paralysis, and loss of sensation, with flaccidity of the muscles below the lesion, the loss of sphincter control, with preapsism and abdominal distension, form a symptom complex denoting a gross lesion of the cord, and the prognosis is extremely grave. Should paresis or paralysis, with diminution or perversion of sensation, be present in the absence of a wound, and should there be headache with a slow pulse and subnormal temperature, the case is probably one of spinal concussion. If rest in bed does not bring about a rapid improvement in the symptoms, lumbar puncture should be performed and the cerebrospinal fluid allowed to escape very slowly until the rate of the drip from the cannula becomes normal. As much as 2 test tubes full of fluid may be removed. Massage to the affected limbs should be daily carried out until recovery is complete, which usually takes about 3 to 6 weeks. If paralysis be due to hemorrhage, and the X-ray shows the absence of a foreign body pressing upon the cord, and if the wound, as is often the case, be small and penetrating or perforating, lumbar puncture should be performed and the wound left alone, unless it be inflamed. In the latter case, it should be excised and opened up, and a Carrel-Dakin or Flavin dressing applied. Rest in bed with lumbar puncture is often sufficient to effect a cure in these cases, and the missile can always be removed at a later date if necessary. It may be necessary to repeat the lumbar puncture, and in every case the fluid withdrawn should be carefully investigated bacteriologically. Should the X-ray show the presence of a foreign body in the shape of a missile or a piece of bone pressing on the cord, then laminectomy must be undertaken. If the wound in the soft parts is situated at some distance from the middle line of the back, the incision should be made in the middle line. If, however, the wound is situated close to the midline of the back, then the laminectomy incision should be planned to include it, and by this means the wound can be excised. The free use of hot sterile cloths and adrenaline is sufficient to stop all hemorrhage. When the wound in the vertebral column has been exposed, sufficient bone should be removed in order to expose freely the dura mater of the cord. Great care is needed here in order to preserve the newly formed subarachnoid adhesions. If the dura is intact, removal of the missile and the depressed piece of bone is all that is required, but if the dura has been opened, it should be treated in exactly the same way as the dura mater of the brain, that is to say, bone should be removed until intact dura is exposed to an extent of 1/4 inch all around the perforation. The wound in the back should now be closed, but a tube should be left in extending down to the fracture of the vertebrae, but it must not in any way come in contact with the spinal cord. Cases of gross lesion to the cord which show a missile or a detached piece of bone to be pressing upon it should receive similar treatment, for although this treatment proves often to be unsatisfactory, yet some brilliant results have been obtained by laminectomy in these cases. Great care should be bestowed upon the backs and points of pressure of these patients. We have from the beginning always used the following preparation with success as a prophylactic against pressure sores: bismuth oxychloride, zinc oxide, oil of eucalyptus, castor oil. To be applied morning and evening after washing the skin with soap and spirit. The greatest care possible should be exercised in the 6-hourly use of the catheter and every aseptic precaution taken. These patients should as a routine be given urotropine 3 times a day. Great care and cleanliness must be exercised in the case of patients with dual incontinence. Bed sores, when once they have formed, should be kept as clean as possible, and for a day or two hot fomentations applied frequently should be employed. When once the sores have cleaned up, scarlet red ointment makes an excellent application. Cystitis should be treated by lavage, and perhaps the best solution to use in this connection is half-strength Usol. Spinal meningitis is best treated by repeated lumbar puncture, combined with the use of an autogenous vaccine. End of chapter 26. End of War Surgery from Firing Line to Base by Basil HUGHES and H. Stanley Banks.